So our next speaker is Dr. Rajendran Dinesh Kumar, Assistant Professor, Department of ENT, Rajarajeswari Medical College and Hospital, Bengaluru, Dr. MGR Educational and Research Institute, Chennai. So he will be presenting a session on the role of biologics in allergic disorders. Over to you, sir.
Am I audible, ma'am?
Yes, sir, you are audible.
Yes. Very good evening to one and all. I am Dr. Rajendran Dinesh Kumar, and I'm here to talk about the role of biologics in allergic disorders. Biologics are a class of drugs which are large complex molecules which are derived from the living organism, biotechnological process. They meet the criteria of precision customized treatment, and they are actually an add-on therapy and not a standalone medication. They are indicated for patients who are having high frequency of symptoms both in the day and night, and those are using asthma medications like short-acting bronchodilators for more than 2 times a week. It is also indicated for severe asthma, and also it is used for patients who are visiting the ER, that is the emergency room, more than 2 times a year. This presentation will be an overview and an update on the role of biologics in allergic disorders. So the key characteristics of biologics, what do they actually contain? They're actually the living organism medications with high complex molecules, and they actually target the particular interleukins, and they are highly immunogenic, and they have high response of variability. Prior to starting biologics, we must always contemplate whether the patient is following the correct prescribed medications, like their asthma medication, their allergic medication, the sprays, and is the patient following the correct preventive and control measures at home and at workplace. Are there any new identifiable triggers? Are there any undiagnosed comorbid conditions which has creeped up of late? Are there any drug-drug interactions which have led to certain new changes? The present indications for biologics are in asthma, atopic dermatitis, chronic spontaneous urticaria, food allergy, and chronic rhinosinusitis with nasal polyposis. As per this list, you would have noted that these are all very chronically debilitating conditions which influence the daily lifestyle of our patients. So here is the global initiative in the treatment of asthma. There are different steps for treatment here. We should focus on the step 5, where this is the role of the biologics, where we have to start for asthma patients. So this is for children above the 6 to 11. Unfortunately, there are no available biologics less than 6 years. Now, for adult and adolescents above 12 years, step 5, biologics are also contemplated. So the burden of oral corticosteroids are high because of their use, because the knowledge of biology are very limited, and this as of now accounts to 89% of the use of oral corticosteroids per year. And we all know what oral corticosteroids can do, and its side effects and its association and its side effects with comorbid conditions like diabetes, hypertension, and peptic ulcer disease and other comorbid conditions. So here, our first biologics which we'll be talking about is omalizumab. It was FDA approved in the year 2003, and it is actually acting at the level of the anti-IgE antibody. And they actually interact with the Fc epsilon receptors, which are located in the mast cells and the basophil cells, which are critical in the allergic cascade. So they are indicated for children above, or patients above 6 years, uncontrolled severe and moderate asthma, and also for those who are having perennial allergic diseases. And it's given at a dose of 75 to 375 mg subcutaneous. Now, how is the dose actually calculated? We actually calculate on the basis of the body weight and the pre-treatment IgE levels, that is the immunoglobulin E levels. It is indicated for asthma, chronic rhinosinusitis with nasal polyposis, and chronic spontaneous urticaria. What are the outcomes when we use these medications? There are also other off-label uses, but we will not be talking on that. And here it is focused mainly on allergy. So the outcomes are it reduces the acute exacerbation by more than 25 to 60% and reduces the need for hospitalization and the intranasal corticosteroid dosage. And the adverse effects being anaphylaxis, which is there in 0.2% of the cases, and injection site reaction and constitutional symptoms. Now, mepolizumab is another monoclonal biologics which are there in the form of anti-IL-5. It acts at that level. It's a protein which is mainly involved in the development and activation of eosinophils, which are the main allergic and asthma reactions. And here it is FDA approved in the year 2015, and it's again indicated above 6 years for uncontrolled severe eosinophilic type of asthma. It is given in a dose of 100 mg subcutaneous, and it reduces the asthma exacerbation by 50%, and it has certain side effects like hypersensitivity reaction and even herpes zoster infection. So for this, the patient may require certain vaccinations for recombinant zoster vaccines, 2 doses apart, 0.5 ml each. Now, reslizumab is an anti-IL-5. The most peculiar feature of this biologics is it is the only intravenous available biologics. It is approved in the year 2016, which acts at the level of IL-5, and it is indicated for uncontrolled severe asthma, predominantly the eosinophilic phenotype, and here it requires hospital administration. The previously shared biologics can be given in the form of home dosage and also in-office treatment. Here, the outcomes are it reduces the asthma exacerbation and the need for oral corticosteroid dose upscaling. The adverse effects are no less. The anaphylaxis is 0.3%, and there is worsening of asthma and esophagitis and constitutional symptoms, and even elevated baseline serum creatinine phosphokinase levels. Now, the other ones like Talazumab is an anti-IL-5R. It is approved in the year 2017 by FDA. It is mainly used for severe eosinophilic asthma above 6 years. And here it is given at 30 mg subcutaneous dose at 4th or 8th weekly intervals apart. And here it also reduces 35 to 55% in the asthma exacerbation. And the side effects also are hypersensitivity reaction of 3% and injection site reaction and constitutional symptoms like upper respiratory tract infections. Now, the recent studies which are also ongoing, like the Sirocco study, the DREAM study, and the Innovate study, all this table shows that the acute exacerbation of asthma by the use of these biologics has been reduced, and it has significantly improved the patient's quality of life by almost 40 to 50%. These are the current data, and this is right now the most common available biologics. They are actually having some adverse effects, but these are generally well tolerated in the respective trials, and most likely the adverse effects being upper respiratory tract infection and constitutional symptoms, to name a few. To continue this list on forward, the latest ones which are right now in the market are dupilumab, which is an anti-IL-4 alpha, and it also acts at the level of IL-13. And these are actually used for about 6 years patients and in uncontrolled severe eosinophilic asthma, and more important line, for oral corticosteroids dependent asthma patients. It was FDA approved in 2017, and it finds its use in atopic dermatitis. This is a very chronic problem, especially amongst those who are having family history, and also it helps them dramatically change their quality of life. It is also indicated in the chronic rhinosinusitis with nasal polyps. In the future, the ENT surgeon may probably run out of jobs because they may avoid surgeries, and this particular drug can be a magic drug, but at the moment, the cost is a contemplating factor. Here, the outcomes are it reduces the 50% in severe asthma exacerbation and the need for oral corticosteroids use. And here, there are certain side effects which are in the form of adverse reactions like injection site reaction, transient eosinophilia, and rarely ophthalmic inflammation. The tezepelumab is an anti-thymic stromal lymphopoietin blocker. It is indicated for more than 12 years patients, and it is here that we have to consider this particular biologics in uncontrolled severe asthma without any phenotypic or biomarker limitation. Here it is also used in those patients who are resistant to oral corticosteroids. This becomes a boon drug in the future amongst patients who are not responding to oral corticosteroids. It was FDA approved in the year 2021, and it also finds its indication in COPD, chronic rhinosinusitis with nasal polyp, and urticaria. And also it is given in a subcutaneous dosage, 4-weekly interval, and also home dosage pens which are used by the patients. The adverse effects include pharyngitis and back pain. Here, these are a table chart which shows the available biologics, and this is just to summarize that all the list of the biologics, their indications, their route, and their dosing. And I would like to bring this to your notice. Sinquare, that is the reslizumab, is the only biologics which are given IV, and the rest are given in the subcutaneous route. Now, when it comes to food allergy, we daily eat food and we have patients who come with food allergy. Is there any role of biologics? At present, there are no FDA approved drugs for that, but omalizumab, that is the anti-IgE drug, has been successful in the management of certain food allergies like peanut, cow milk, and hence egg, in combination with oral immunotherapy, which has helped to show rapid desensitization. Other potential drugs which are available as targets are anti-IL-4R and anti-alarmins. Now, in the future, the biologics which are under study are anti-TNF, anti-IL-33, and anti-neutrophilic biologics. There are other IL-13 monoclonal antibodies, which are available as nebulization, but it has been done in animal study, but it has found to be ineffective. Other therapies are lebrikizumab and ledolizumab. They are very highly affinity to IgE, but still they are under study and as of now ineffective. Now, the points to be noted is, how do we consider that the patient is having any form of response? So at present, there are no very well-defined criteria for a good response. So they are defined as unclear, no response, or reviewed for response, or a good response. We say the patient has a good response when he has responded and there are no symptoms after a treatment of 1 year. We say there are no response when the patient has completed 4 to 6 months of treatment. And we say when it is unclear when the patient has completed for over 1 year of treatment, but still there is no response. We have to be patient and contemplate that biologics alone may not help, but we have to follow other medications like antihistamines, oral corticosteroids, inhaled nasal corticosteroids, and other preventive measures to go hand in hand. Now, to conclude, the emergence of the biologics have dramatically transformed the management of difficult and different biological allergic disorders. And I hope in the coming days, there are more personalized and effective treatment for the management of different allergic disorders. The take-home message from this talk, if somebody has to take home certain important details, the cost is one of the factors. If I have to add one more C to the already existing 5 Cs, the cost is an important factor as of now. Its availability is an important factor as of now. And we have to give it for the correct diagnosis, correct medications, correct patient, correct technique, correct compliance, and also have to check for the comorbidities. As of now, for asthma, it is being used for type 2 debilitating asthma. Omalizumab is used. And in atopic dermatitis, dupilumab is used. And we have to give for the correct indications. And as and when we are giving these medications, we should have our crash card equipped. And we have a good critical team management for managing of critical cases and certain issues like anaphylaxis and hypersensitivity. So it's better to have the patient waiting in office for at least 3 to 4 hours after giving the biologics. So these are my references, and I would like to acknowledge my teachers from the FEB course, which are my allergy colleagues, Dr. Vedantan sir, and Dr. Satish Roy, Dr. Gayatri ma'am, and Dr. Bala sir. And thank you for your patient listening. Belchoy Spasiba. Thank you.
Thank you, sir.
Thank you very much. Okay. Have you any questions? Have you any questions in your hall, in India hall? No?
Yes, sir.
Okay.
Yes, ma'am. Sir, are there any alternative equivalents to biologics is available? Suppose for the patient for cutting the cost, considering the cost, if the patient wants to go for an alternative equivalent to biologics, what might be the option for the patient?
As of now, biologics are very few and limited in numbers, and the cost has initially come. It was very high initially. In India, it was around, omalizumab was available at 15 to 20,000. Now it's come down to 7 or 8,000. And there are some similar drugs called biosimilars. They are not like biologics, but they are similar to the biologics. So they are also available at a lower cost. But mind you, these drugs are specific targeted treatments. So as of now, their availability in India is subject to availability and also the cost being a critical factor, because this medication has to be given every 4 weekly or 6 weekly, depending on the response. And the patient should also be motivated to find that they should take this course of treatment for at least years, at least 1 year, to say that they have responded from it. And moreover, this is something which the patient will get sensitized slowly to develop a response. So as of now, cost is a factor. I don't know if my Russian colleagues can help us out about the availability of these biologics there. In India right now, we have omalizumab and dupilumab. Other drugs are available, but they are a big shortage of these drugs, and availability is one concern. And when such expensive drugs are there, there is also a question on its originality. So because the cost is so high and the patients are those who are in the step 5 of the management, they hardly find any response, and this becomes the only drug then. So we have to find whether the correct logistics, correct pharmaceuticals, and the genuinity of these products are available to address the patient's needs and demands. Thank you.
Okay.
Any
Thank you.
questions from Russian delegate side?
Okay. Please, Dr. Vasily, please.
I want to ask one question. What do you think, in what cases or in what groups of patients this group of drugs may be contraindicated?
Okay, contraindications for these drugs include those who are having adverse reactions, those who are immunocompromised, those who are having certain previous reactions, and the things are the data on the adverse reactions are limited as of now, but we know that these are going to act at the genetic levels and also at the potential biochemical levels. So that is where it finds its benefit. As of now, there is no such subjective genotypic assessment. As of now, all our assessments are based on the phenotypic assessment. So in the future, maybe if there are certain genotype assessment where patient can be subjected and only those, but then it will be good. As of now, not all patients are alike, and the phenotypic presentation can vary amongst patients.
Thank you.
Very much. Dr. Tatiana, please.
I would like to ask you one question. Are such drugs capable of being addictive?
No, the drugs are given. See, these drugs are administered by the hospital authorities and are given as a home care medications for rescuing the patients. Now, if you have an atopic dermatitis is very common amongst those who are having family history of atopy. Your child or any elderly patients who are having atopic dermatitis, when they develop those severe reactions, these may become the only life-saving drugs. We all know how adrenaline is useful in the dose of 0.5 ml given intramuscularly for anaphylaxis. So when some cases when steroids don't help, the antihistaminics don't help, and the chronic treatment for urticaria, like you have given single dose antihistaminics, double dose antihistaminics, you have given a trial of other drugs like cyclosporin, and you have given omalizumab, and still there is no response. Then you have to upscale your available biologics, that is dupilumab, which is latest available for the patients. They are not addictive and they are given at an interval of 4 weeks as a single shot or 8 weeks maximum. And they are administered at home by a proper prescription by the doctor. And they are not available without prescription.
Okay, thank you very much. We hope that this group of drugs will be in future will be used very widely for the treatment of allergic disease. Okay.
Thank you. Thank you, delegates. I'm very happy to introduce our Dean Ma'am, Pratna B. Dolia Ma'am. Ma'am is an eminent person, Dean of our Institute ACS Medical College. Ma'am is joining in our hall right now. So thank you, Dinesh sir, Rajendran Dinesh Kumar sir.
Thank you
So
very
we
much.
are very happy